Dr. Jennifer Downey is editor of the Academy's journal, Psychodynamic Psychiatry, with Cesar Alfonso. She is clinical professor of psychiatry at Columbia University in New York and is also in the faculty of the Columbia University Center for Psychoanalytic Training and Research. With Richard C. Friedman, she has written about sexual orientation, sexual fantasies, and sexual minorities. Her current interests include women's health, minority and non-minority sexuality in people with psychiatric disorders, and individuals with medical illness. And Dr. Downey is going to speak to us tonight on taking a sexual history, the adult psychiatric patient. Jennifer, I turn the floor over to you. Thank you.
Thank you, Jerry. Well, listen, I'm very honored and pleased to have a chance to talk about taking the sexual history with you, my colleagues and friends of the Academy. And I'm going to be taking the sexual history and how it can shed light on the psychiatric treatment of patients, our patients. And my comments are going to be based on work that Richard Friedman and I did together for over several decades on the sexual history. Few may know it, but Rick and I were both sex researchers before we became psychiatrists. As a result, we usually took sexual histories from our patients and we used that information as psychiatric residents. Years later, Rick and I were drafted to develop and lead a required course for adult psychiatry residents at Columbia University College of Physicians and Surgeons. And its title was Human Sexual Development and Pathology. The course was 12 sessions for late PGY3 residents. We started out with high hopes, and the first year we assigned the classic papers and monographs. No one got through them. We looked again and we could rarely get through them ourselves. There's very little writing about sex in psychiatry. Most of it came from other fields. It was boring, it was statistics driven, and there was an unfortunate amount of guinea pig research. Rick and I regrouped. We changed the course. We decided psychiatric residents would learn better by doing. And we taught them how to take a sexual history and how to integrate it with information that they already had about the patient. And then we asked them to take a sexual history from one of their patients, to write a report and present it in class. And we were much benefited in this running this class by the fact that it was required, which meant that everybody had to turn in the homework. Residents were anxious but excited. No one knew what would come out in the next history. It rapidly became clear that people had not found out these things before, even when they had been working with the patient for several years. We taught this course for 23 years. I think of the sexual history as similar to a physical exam or a mental status exam. It is a skill that you learn. After that, you can use the relevant parts to assess your patients. You don't have to do the whole exam every time. Sexuality is lived in a culture, and cultures change. As a result, we have to thoughtfully update the questions we ask. As we talk about the sexual history, I'll point out some places where we need to update ourselves. We also must use clinical tact. We should never assume that other people's sexuality is like ours. And in fact, that's one of the reasons why I like this work so much, because no one ever tells me the same thing twice when it comes to taking a sexual history. Everybody has a different story. So let's have the next slide, please. This lady is reading a book that's titled Everything You Never Wanted to Know About Sex, but Were Afraid Someone Would Tell You. And I think I always have liked it because to me, it represents kind of how our residents were feeling when they started the course. Now, let's go on to the next slide, please. I'm going to say something first about the DSM. The DSM is kind of like the Bible, I feel. You may not believe it. You may see problems with it, but you have to know what's in it. And for us psychiatrists, we really have to know the DSM. And the DSM-5 TR just came out last month. And I just got my copy, and you probably have too. And there are just a few sections on sexual disorders in the DSM, and they are comprise sexual dysfunctions, gender dysphoria, paraphilic disorders. And then if you look for sexual abuse, you find that it is not in any mental disorder category. It is one of the, quote, other conditions which may be a focus of clinical attention. So it's in the back of the book, and it is given a Z code by the ICD-10. Let's go on to the next slide. I'm just going to spend a bit of time on what the DSM says because essentially I feel like it tells us very little about our patient's sexuality, but it's still, we have to consider what is there. And this first slide describes their very mealy-mouthed, in my view, description of sexual dysfunctions, clinical significant disturbance in a person's ability to respond sexually or to experience sexual pleasure. There's nothing really wrong with it, but it doesn't have much spice. And they divide sexual dysfunctions into primary or acquired, and they sexual dysfunctions are really, if you think of that human sexual response cycle, which looks like a bell curve in textbooks about sexuality, at each point in the bell curve, there are a few sexual dysfunctions. So there are sexual dysfunctions in the first part of the bell curve, which is desire, interest in sex, desire, and arousal. And then there's another group of sexual dysfunctions that are orgasmic disorders. And then there are pain disorders, which are usually dyspareunia and vaginismus. Those are disorders that are unique to women. Now, it so happens that although rather few of us, I think, are consulted by patients with their chief complaint being a sexual disorder, sexual disorders are extremely, sexual dysfunctions, that is, are extremely common. And the last population-based study in the United States of sexual disorders in individuals, so these were just a community sample, 31% of men and 43% of women had at least one sexual dysfunction. So that's a very high prevalence, especially considering that they're not consulting us for them. Let's go on to the next slide. I wanted to start with gender terms before we talk about gender dysphoria, which is the only gender diagnosis in the DSM-5 TR. But you know, in this day and age, there are many gender terms, and the way the DSM defined gender terms is, it says, gender is the public, sociocultural, lived role as boy or girl, man or woman, or other gender. Usually this is the birth assigned or natal gender. Now, in actuality, there is a lot of variability in gender, and there are a lot of terms. And some of the terms I put here on the slide, there's gender atypical, gender nonconforming, gender variant, gender diverse, non-binary. And someone was telling me that in their hospital, their medical history program offers 80 terms for gender. I'm not sure whether that could be possible, but I thought it was amazing. And then there is also the term transsexual, which is now considered to be, as the DSM says, an historical term, which refers to an individual who seeks to or has changed their social presentation of gender, and oftentimes has received somatic treatment. So transsexual is kind of dated now as a term. Let's go on to the next slide. So the new term, this is important because DSM-5 has changed from the DSM-4. The DSM-4 referred to gender identity disorder, and DSM-5 TR has changed to gender dysphoria. So we no longer have a gender identity disorder as a diagnosis. And what, in general, how they define gender dysphoria is as a marked incongruence between one's experienced gender and assigned gender of at least 6 months, and the condition is associated with clinically significant distress or impairment. And there are different manifestations. This is a condition that can present itself in childhood. It can also present itself in adulthood. And you are supposed to specify if the condition occurs along with a disorder of sexual development. And the reason for that is that many people who are born with intersex conditions actually fall somewhere in the gender non-binary spectrum. So it's a very interesting thing that's happened. They've gone from a category of gender identity was really a categorical diagnosis, gender identity disorder, and now what they've really done is their concept is much more of a spectrum, which I think fits more the clinical data. Okay, so let's go on to the next slide. Still talking about the DSM-5. Okay, paraphilic disorders. They define this in the DSM as any intense and persistent sexual interest other than the usual interest in genital stimulation or preparatory fondling with normal, physically mature, consenting human partners. So there are a lot of paraphilias, and there are hundreds, actually. I think John Money used to have a long list of them, but the ones that the DSM lists are just 8: voyeurism, exhibitionism, frotteurism, sexual masochism, sexual sadism, pedophilia, which is the one we really talk about the most, and fetishism and transvestitism. So that is what I wanted to say about the DSM, and what I'd like to go on to is what else there is to talk about when you consider a patient's sexuality. So let's go to the next slide. The initial interview must be sensitive to clinical context. That's really a little bit out of order there. Our point in this slide was that you don't start just by asking a patient the same list of questions. Each patient, you have to start with where the patient is coming from. And remarkably, interestingly to me, I was just thinking about this today, remarkably few patients come with sexuality as their first problem, their chief complaint. At least it is true that I myself have seen a lot of people who wanted letters so they could get gender transforming surgery. That's really a thing of the past. People are doing that much less now. But overall, and a few people come and say, am I gay or straight? But overall, what intrigues me is that the ordinary person who comes to you with a complaint of depression or anxiety or panic disorder, these different things that are very, very common presentations for us, all of those people end up telling us, if we have time to listen, something about their sexuality, and a lot of times they have difficulties. And someone comes to mind who saw me for anxiety, and in the middle of this conversation about anxiety, she suddenly sort of said, you do know that I've never had sex with a man. And it all has to do with my brother. And then she went back to talking about what she was talking about before. And I swear, there was not anything in this presentation of this patient that would suggest that she had any concerns about sex, but obviously she did. And that's something that's going to be very important to talk about. Let's go on to the next slide. The clinical history should be developmental. I think that's probably what this says. My point here is that sexual development and the social experiences of being a sexual person start at a very young age. And so it would be quite incorrect for us to think of sex as something that starts, say, at puberty. And so what we're going to be talking about is the developmental things that happen before you reach puberty. Those are very important. Okay, next slide, please. Okay, the point here is just that psychosexuality is a very big part of development, and adult erotic sexuality is only part of it. And in fact, I would say the smaller part, but it depends, I guess, on the person. Let's go to the next slide. We come here, well, let's see, I think that, can we go back? I think we've got somehow jumped ahead. Okay, well, somehow or other we've missed one or two. Let me just make a few comments then. One of our tasks as clinicians is to understand how sexuality and attachment issues are intertwined with the patient's psychiatric disorders. And that is a rather tall command. We have to ask in order to find out. But if we ask, we can learn a great deal. And that's what we're talking about today, is how to ask. Because patients will not necessarily tell us off the bat. Let's go to the next slide, please. Okay. Now, what does psychosexuality consist of? It consists of childhood sexuality and attachment. It consists of gender. It consists of sexual orientation. It consists of romance and sexual relationships in adolescence, adulthood, and late adulthood, and sexual symptoms and dysfunctions. Let's go ahead. in this slide, I'm talking about how every adult individual is a sexual person, whether or not they are celibate, whether or not they are, whether they have a partner, whether they have had a partner. All people are sexual. And when I think about this, the topic of celibacy, I'm reminded of my experiences as a very young psychiatrist. For some reason, the Catholic diocese in New York started sending me priests for treatment. They weren't pedophilic priests. They were just ordinary men with anxiety or depression or other rather humdrum psychiatric problems. But I thought that they would be celibate. This was completely shows my naivete, because the first person that ever became my patient from this group of priests was a man who was a serial monogamist. And every time he was moved to a new parish, he would find himself a new partner, an adult woman who was in his parish, who was very pleased to serve the priest and take care of him and be his partner. And when he moved, he found another woman. And I was dumbfounded by this. Okay, let's have the next slide. I can't see this. Oh, okay. The clinician picks based on clinical appropriateness what questions about the sexual history to ask any particular patient. And I'm reminded that Rick and I talked once about how you start a conversation about sex. And he said, I still remember his saying, sometimes I ask them, do you have any sexual worries? And it stuck in my mind because I think that sexual worries, many people have sexual worries, and it's a very non-confrontational way to start a conversation about sex. Okay, so let's have another slide, please. In this slide, I'm talking about how sexuality is not just wrapped into the patient's life, but also the mental disorders that we're treating them for. And that what we were doing when we taught our course was we taught the young physicians to make a connection between the sexual developmental things that had happened to the patient and the psychiatric and trauma experiences that they'd had. And we made a timeline, they made a timeline for those things. An example of that would be somebody who comes to you and says that they've been depressed since they were 10. This is a young woman, and you ask her, I'm interested to know when you had your first period. Now, when I asked that, I was thinking to myself that at the time of one's first period is a time when the prevalence of depression in girls doubles compared to boys. And so the patient said, I had my first period when I was 11, and it was the worst day of my life because I realized that I was going to have to be a woman. So in that case, it was a chance that was turned out to be an opening into the issue that she had about her gender, which came up because we were talking about her, first of all, her depression and when her depression started. So that's how they can travel together. Psychiatric symptoms and sexuality issues. Let's go to the next slide, please. Okay, we have to ask to find out. I think we talked about that already. Let's go to the next slide, please. Okay, now we're coming to something that's quite specific about what are the domains of the sexual history. And demographics actually tell you a lot. The age, the gender, the marital status, and whether the patient has any children. That's all important. The ethnicity of the patient, the culture of the patient, and his or her religion. And religion means both religion of upbringing and religion, currently practiced religion. Now, in a country like ours, which is still rather secular, I would say, many people will say, I don't practice a religion. But if you ask them about the religion that they were raised in, a lot of times that turns out to be very important, because people who engage in sexual behavior in adulthood that is forbidden by their religion oftentimes have great guilt and shame over their sexuality, even though they no longer practice that religion. It's a fascinating thing, and religion is one of the things I think that is most important to consider in understanding how patients feel about their sexuality. Circumstances of upbringing, education, occupations of parents, degree of security and comfort. And I think degree of security and comfort is the most important thing there. Because if you don't have security and comfort as a child, first of all, you're exposed to many more psychiatric, those are traumas, not to have those things, and you become more vulnerable to psychiatric disorders and also certain kinds of sexual disturbances. Let's have the next slide. Oh, another domain of the sexual history is current sexual relationships. That's often an easy place to start. Degree of difficulty, degree of satisfaction, and past sexual relationships. And Rick and I always tried to ask for every patient. We did ask about both opposite and same-sex partners. And you don't have to keep on doing that with every single question, but it is important to find out whether people have engaged in sexual behavior with both speakers and other things. So go on to the next slide, please. Childhood development. Here's some other things you'd like to find out about. If you have a patient you're going to be working with for a while, the attitudes of parents and caregivers towards their own sexuality and towards the patient's sexual development. And in particular, I think something that's often overlooked is sexual behavior between siblings, which is rarely written about as sexual abuse. And it may not be sexual abuse, but sexual behavior between siblings, especially if there's a large age difference or power difference for whatever reason, can be quite abusive. And patients' experience of sexual development, age of puberty, first menses, feelings about the body. In the case of the young woman that I was mentioning a moment ago, who said that the day of her life was the day she had her first period. She had many painful feelings about her body, and she had become much more severely depressed when her previous therapist had talked to her about having top surgery And this young woman said she was thinking about having top surgery, which means having her breasts removed. And the therapist was obviously not expecting that, was quite unprepared. And she said, "Oh, that is terrible. That would be a mutilation. How could you consider such a thing?" And after that, the patient became much more depressed. Okay, so let's have another slide. Milestones. Anybody who's heard me talk about taking a sexual history knows about these milestones. Pediatricians and behavioral psychologists love milestones. Milestones are the first age that you achieve something. And for instance, a common, if you think of the Denver Development Test, to stand and walk, you know, you at the, I think the mean time to do that is about 12 months. That's on that which we were all taught in medical school. And in behavior, there are also milestones. What that means is the first time you do something and it becomes part of your social repertoire. And the romantic milestones that behavioral psychologists talk about are such things as holding hands, dating, having a boyfriend or girlfriend, age at first falling in love, age at first married or established a committed relationship. And you would ask that for opposite and same-sex partners. Let's have another slide, please. Sexual milestones are similar. This would be age at first kiss, age at first kiss on the lips, age at first holding hands, age at first experiencing oral sex or performing oral sex, age at first experiencing penetrative sex, and age at first masturbation to orgasm. And that is for opposite and same-sex partners. Interestingly, to me, I've always felt that the question about this is back to the romantic milestones. When you ask someone who their first crush was, it's a very intriguing thing to me that everyone remembers the name of the first person they had a crush on. And for the sex of the person who you first had a crush on is often quite telling in a person's sexual history. And oftentimes, you know, someone who is a gay person who's an adult will tell you that the first person they ever had a crush on was their male teacher, male camp counselor, say, when they were 8, or someone who is heterosexual will tell you that she, the patient, her first crush was on somebody's older brother when she was 6 years old. So a lot of times, I'm not saying that predicts the future outcome, but I think it's an interesting relationship that I've often encountered. So let's have another slide, please. Sexual orientation. You know, one of the things, Rick and I wrote more about sexual orientation than about anything else. And one of the things that's very interesting about it is there's no official there's no official definition of it. So the way we tended to think of it was that sexual orientation involved 4 different aspects. It involved behavior, sexual activity. It involved fantasy or attractions. And it involved identity, which is the feeling of what you are, which is a personal and private feeling. And then social role, which is what you present to others. And we have here, has the patient come out, and to whom and when? And that's a very, always a very valuable question to ask anyone who believes that they are gay, because have they come out to anyone is one very important thing. And if they did come out, and to who, what happened? And what's a very interesting thing that I think is that a lot of times, we think of people as being very honest with their families and maybe not sharing so much with friends and coworkers. But when it comes to sexual orientation, many people have not come out to their families, but they have come out to coworkers, they've come out to friends, they've come out to other people of the same minority sexual orientation. In any case, anyone who has come out has a story to tell, which you can find out. Let's have the next slide. Gender. This is an old slide, so it talks about gender identity, which we have now really moved away from, this gender identity. But as a concept, as a diagnosis, I think it's right that we moved away from it. But gender identity still has some meaning as the feeling of what you are. And whether you are male, whether you are female, whether you were somehow put in the wrong sex, people sometimes feel that way. Or maybe you are somewhere in the middle, somewhere between male or female. That is something an idea that not so many people entertained in the past. I think there have always been people who were in the middle, who were non-binary, but it's a much more popular concept now, and it's gotten into the popular culture. Gender role, we talked about that a bit earlier, about how you present yourself, whether male or female, masculine or feminine, and gender self-esteem. And gender self-esteem is something that Rick and I wrote a lot about, which is we associated it with late childhood. And we said that we thought that gender self-esteem was often impaired in young people who were atypical. So if, for instance, you were a gentle boy and you were not particularly athletic, you could suffer from problems with gender self-esteem, whether you were pre-gay, whether you were going to be straight. You could still, or if you are a target for bullies, that affects gender self-esteem. And we wrote several papers about that. Let's go on. Okay, trauma. Well, I think we all think more about trauma than we used to, and that is a very useful thing that we're doing so. And there are so many kinds of trauma. What I've put here is just physical abuse, sexual abuse, including non-consensual sex and boundary violations, and other trauma. And there are so many different kinds of trauma. What I've listed here is homelessness and loss of a parent at a young age. I think right between the pandemic and the war in Ukraine and all the different things that are happening, we're seeing a great deal we're all learning more about trauma than is imaginable, really. And there's trauma affects, as we all know, everybody here knows this, that trauma affects psychological and health and affects psychiatric illness. Let's have the next slide. Special issues, reproductive issues, such things as reproductive events. There are a lot of folks in my practice who are having difficulty conceiving. I'm sure that other people, that you too have many patients in this category. Safe sex is something that is a very interesting topic to me because I've had so many experiences where people told me that they always engaged in safe sex. And when I asked them what safe sex meant to them, I found out that they weren't engaging in safe sex at all. So I once had someone who told me that he always engaged in safe sex, and he was a physician, and I thought that he knew what safe sex was. And 6 months later, I found out that his idea of safe sex was that he did not have any other partner than his one partner, but his one partner was very promiscuous. So my patient was really not engaging in safe sex. Let's see, I can't see this last one. Does it say sexual dysfunctions? Okay, we talked about that already. Let's go on. Additional special issues: impulsive and compulsive sexual behavior and paraphilias. I myself have found that it can be difficult to find out whether people are engaged in impulsive and compulsive sexual behavior. And sometimes you find out because a patient is sent to you by their spouse who's complaining of their behavior at home, that they're watching too much porn at home or too much of some kind of television. And paraphilias are also, it's paraphilias, people are ashamed of them. I think it's rather hard to get people to tell you about them. And I've tried different ways to interview patients about this, and I oftentimes will ask them what is the most illegal thing they've ever done sexually, or the most unusual thing they've ever done sexually. And I remember once that I love this. Someone gave me, it was a young man, unmarried man who was dating, and he said, I had sex with my girlfriend on the Long Island Railroad. So I decided that based on this as being the most illegal thing he had ever done sexually, I decided he was probably not a paraphiliac. Okay, let's go on. Difficulties for older people. Menopause. It's surprising how many people who go through menopause and suffer from dyspareunia do not know anything about hormone replacement or the use of lubricants. They feel that this is something they should put up with. So it is an area in which we as physicians can help patients if we find out that they are having a difficulty in that area, or even that they're going through menopause. Certain medical illnesses affect sexuality, of course, heart disease, diabetes, surgeries on sexual parts of the body. I'm sure that everyone at this talk has had at least one patient who's had her breast removed because of breast cancer. And some of the women who've had this done have been devastated. It is such a huge injury to their feeling of sexual self-esteem. And they also, of course, they lose the sensation from the breasts, but also they feel so wounded. So that's and of course, genital surgeries as well. And finally, side effects of medications such as SSRIs. It behooves us to ask people that they're having symptoms from our medications, because Many a person has stopped their medicine because they don't like the side effects, and they don't necessarily tell us. And obviously, that's not good if our patients are not taking our medicine. We have to figure something out, give them something different. Let's have another slide. Sexual fantasies. You can't see this one, so I don't know what I said. Conscious erotic fantasies and romantic fantasies. One of the things that's different about the way Rick and I approach the sexual history is that we focused, the thing that's different is that we're psychoanalysts, but we are talking here about conscious fantasy, not unconscious fantasy. Conscious erotic fantasies. I think every man I've ever met knew what his erotic fantasies were. But not every woman knows what her erotic fantasies are. Some women have not yet had erotic fantasies. And for some women, romantic fantasies serve the same purpose. That is, they're associated with arousal, but they don't have anything, what we would consider to be erotic in them. They are romantic fantasies, but very exciting to the woman. So if someone has only romantic fantasies, that would not be a sign that there's something wrong with them. That is a normal variant of being female. Okay, let's have another slide. Yes, I thought I'd share a vignette with you, a clinical vignette. B was a 24-year-old single white laboratory assistant referred to the outpatient department of the residence clinic 3 months after voluntary admission for abnormal eating and weight loss to the point of 75% of ideal body weight. Her diagnosis was anorexia nervosa, restricting type. The outpatient psychiatrist thought B also suffered from anxiety disorder, not otherwise specified, and she had been seeing a nutritionist, taking multivitamins, and she was on no psychiatric medications. The resident took a family history from B and learned that many people in her family had disordered eating. Her personal history was noteworthy for the fact that her parents separated when she was 5 years old. After that, she lived with her mother. With great difficulty, over a period of several months, B reported to the outpatient therapist that her father had begun sexually abusing her even before he left the house, so when she was 5, by showing her pictures of his genitals and pictures of himself with a variety of women. After he left the house, he visited frequently and would expose himself to her and photograph her nude. He told her it would be a shame if she reached age 18 as a virgin. B is still telling the psychiatrist what happened during the subsequent 4 years when her father maintained a relationship with her. When she was 9, she told her mother about the sexual contacts. B's mother said she would never have to see her father again. And she moved with B far away. The patient saw her father only once after that, at age 13. She does remember that she liked getting hugs from her father and missed him when she no longer could see him. With regard to her personal sexuality, B is attracted only to males and had her first boyfriend at age 15. She recalls feeling ugly and unattractive and ending the relationship when it took a sexual turn. Even when she had an active eating disorder, she says she never thought about her body's shape or weight. Rather, she focused on control of calorie intake, control of her appetite. After a brief period at age 19, when she engaged in sexual intercourse with several different men while under the influence of alcohol, she had avoided sexual contact with men and had not had a boyfriend in 5 years. On dates, she feels awkward and worried that she will be thought to be a bad person. She avoids noticing men and does not seek out relationships. B said to the psychiatrist, "I have a total lack of interest in sex. I am afraid of men and do not want an intimate relationship. The idea freaks me out." It's such a beautiful example of how somebody's psychiatric problem and her sexual problem are woven together. And I don't think anyone would have known about the sexual problem if it hadn't been, they didn't know about that in the inpatient unit. They only, it was learned about because the psychiatric resident in the outpatient clinic was open to talking to her about her experiences. Let's go on, please. This is just a general idea that I think that we have more therapeutic power if we can talk to patients about sexuality. And when we do talk about sexuality with our patients, we also learn more about other issues, such as attachment, as in the vignette, where the attachment was so woven in with the boundary violation with her father, but she still loved her father. That was a problem for her. Okay, let's have another slide, please. References. Let me just make a couple general comments, and then we'll open the floor for discussion. We've been talking tonight about how to take a sexual history from an adult psychiatric patient. I'd highly recommend that everybody here who hasn't done this do it with one patient. You can find examples of the sexual histories Rick and I have taken from patients in our publications, especially our book, Sexual Orientation and Psychodynamic Psychotherapy. The second half of that book is essentially case histories from our own patients. And I'd like to make just two final points. Rick and I both went to the Columbia Psychoanalytic Institute, and we were both psychoanalysts, and I still am a psychoanalyst. And every day I'm very grateful that I took psychoanalytic training when I had the opportunity. Still in all, what we're talking about here, it's not really, of course, it's not a psychoanalytic approach. We're talking about asking questions, not letting the history unfold. And secondly, we're talking about eliciting only conscious information from individuals. And this does not have to do with unconscious fantasy. Or I should say, it does have to do with unconscious fantasy, but we're not seeking that here. We're just asking the patient what they know about themselves. And so those things are conscious. And so I think that it's worth pointing out that these are not psychoanalytic techniques, but they are psychodynamically informed, because what we would like to do with the history is help the patient remember and tolerate and experience the meaning of what has happened to him or her, and feel more comfortable and more able to have a good life.